Hey, BC here for BC Nephro. Thanks for watching. Today we're going to talk about amyloidosis, which is the second main systemic condition that can cause nephrotic syndrome, nephrotic proteinuria. For the full series, we've already talked about 5 primary glomerular diseases that can cause nephrotic syndrome, as well as diabetic kidney disease. For more information, check out the playlist at this channel, which will be linked in the description below, and also check out the articles at bcnephro.com. There will be a link to those in the description below as well. So when we're evaluating a patient with nephrotic proteinuria, nephrotic syndrome, we need to be thinking about amyloidosis as the other main systemic cause of this condition. Not as common as diabetes, but common enough that we need to be thinking about it. Approximately 2% of native kidney biopsies will have a diagnosis of amyloidosis. So what is amyloidosis? So amyloidosis is when certain proteins deposit in tissues in an abnormal configuration, which causes beta-pleated sheets. These end up causing tissue dysfunction. Now, it can be organ-specific or a systemic condition, more often a systemic condition, but certain types of amyloidogenic proteins have predilection for certain organs. Now, there are 3 types of amyloidogenic proteins that have a predilection for the kidneys and cause nephrotic syndrome kidney disease. They are AL, which is immunoglobulin light chain amyloidosis, previously referred to as primary amyloidosis. AA, which is inflammatory serum amyloid A amyloidosis, which has been referred to as secondary amyloidosis. There's another cause, ALECT, ALECT, 2 amyloidosis, which is some sort of leukocyte chemotaxin type 2 protein that can affect the kidneys. Now, the other common cause of amyloidosis that you may see is more predominantly cardiac. That's the transthyretin ATTR amyloidosis. That type of amyloidosis typically does not affect the kidneys. It's more of a cardiac presentation. We're going to be thinking about the 3 types of amyloidosis that affects the kidneys when we're looking at people who present with proteinuria, specifically nephrotic syndrome. Now, most often these cases show up as nephrotic syndrome with heavy proteinuria, average more than 6 grams of proteinuria associated with edema. The creatinine may or may not be normal, and there may or may not be systemic manifestations like cardiac, cutaneous, or other manifestations of this systemic condition. Now, most common type of amyloidosis that affects the kidneys, approximately 85% of the cases of amyloidosis will be the AL, immunoglobulin light chain amyloidosis. So as part of your evaluation for proteinuria, it is important to do serum-free light chains and immunofixation studies to screen for this. Most of these cases will not have overt myeloma, but most of them will have some sort of light chain. And more commonly, it's the lambda light chain, which has a predisposition to form these amyloid proteins and causes this nephrotic syndrome. Secondary amyloidosis, serum amyloid A protein. This is a protein that's an acute phase reactant that's made by the liver in chronic inflammatory states, most commonly described in rheumatoid arthritis, other rheumatologic conditions. There's a condition called familial Mediterranean fever. Can also be seen in inflammatory bowel disease where there's a chronic inflammatory state. This also causes nephrotic syndrome, nephrotic proteinuria, often leading to end-stage kidney disease. Then that type is maybe about 15% of cases. The third type, which is about 3% of cases, is called ALECT2. This is another protein that's made by the liver and causes amyloidosis. This type typically affects the kidney and the liver. It causes proteinuria, but it may not cause nephrotic proteinuria. It may affect the interstitium more and may cause subnephrotic proteinuria with chronic kidney disease. Certain ethnic groups have a predisposition for this, including Mexican people of Mexican descent. So it's something to think about in this population if they're presenting with proteinuria and chronic kidney disease. So as part of your screening, you're going to be checking for these light chains. Most likely, you're going to be proceeding with a kidney biopsy. Now, fat pad biopsies can diagnose AL amyloid, but if there's really significant proteinuria and nephrotic syndrome, you're going to want to find out what's going on in the kidney. If there's not significant proteinuria, then the kidney is unlikely to give you the diagnosis of this systemic disease. But anyways, you're going to do the kidney biopsy, and you're going to see the amyloid, the nodules that are Congo red positive on the light microscopy. Then on the immunofluorescence, you're going to try to figure out which type it is. The immunofluorescence, they're going to stain for the kappa and the lambda light chains. If it is one of these AL amyloidosis, you're going to find restriction to usually the lambda, less frequently the kappa, but both aren't going to stain. There's going to be a monoclonal type of staining that causes this. Now, if it's a secondary amyloidosis, they're also going to be an immunofluorescence stain for this SAA protein. And if you're thinking about this ALECT2 amyloidosis, you're going to want to look into staining for this protein as well at your tertiary nephropathology center, or it may need to be sent out to a place like the Mayo Clinic to look at this. Now, also, there's going to be characteristic findings on electron microscopy. You're going to see these amyloid fibrils. They are typically 8 to 12 nanometers in diameter. There are other fibrillary kidney diseases with different size fibrils, and they should be able to be distinguished based on this size. And then your treatment is going to be based on the underlying cause. So if it's the AL light chain, you're going to be using similar to myeloma-based therapy, even though it's most likely not overt myeloma, with things like bortezomib, daratumumab, cyclophosphamide, dexamethasone to eliminate this clone that is making these amyloidogenic light chains. If it's the SAA amyloid, the secondary inflammatory amyloid, you're going to try to treat the primary condition that's causing the inflammation. And then, unfortunately, there's no specific treatment for the ALECT2 amyloid, but you're going to be using supportive care with renin-angiotensin system blockers, blood pressure control, and things of this nature. So this is an important condition to think about and screen for in your patients presenting with proteinuria, and specifically nephrotic syndrome. If you made it this far, thanks for watching. Like the video, subscribe to the channel, share it with people that you think may enjoy it, benefit, learn from it. Leave comments in the section below. Email me at brian@bcnephro.com. And thanks for watching. Until next time.